and I will talk about the laparoscopic Roux-en-Y gastric bypass procedure and our experience in that. Part of this presentation was given on the Clinical Congress in Chicago in 2009. We were invited to present our results. So to explain where we work, this is our hospital, and we work there a lot. We are a high-volume bariatric center, and to give you a quick overview, between May 2004 and August 2008, we performed around 2,600 laparoscopic Roux-en-Y gastric bypasses, about 200 open Roux-en-Y gastric bypasses, 800 laparoscopic vertical banded gastroplasties, around 1,000 bandings, and until then we did about 20 sleeve gastrectomies. So worldwide, the gastric bypass procedure is considered as the golden standard procedure, but it's surgically, technically spoken, it's a technically challenging procedure which still has a substantial morbidity and mortality. So you operate in young, working and healthy people, and the quality of your surgeon and your outcome must be excellent because the tolerance for complications is unacceptable and must be low. So to prove this outcome, Dr. Dillemans he standardized the Roux-en-Y gastric bypass to a fully stapled, fully standardized procedure to reduce postoperative complications. So we completely standardized the procedure except the anti-colic placement of the alimentary limb or the length of the alimentary limb that can be varying depending on the BMI of the patient, and we performed a fully stapled procedure in which we performed the gastrojejunostomy with a circular stapler and all the rest, the pouch and the enterostomy with linear staplers. So to obtain that standardization, we split the procedure in all different phases in which every participant of the operation has a specific role. Namely, in that procedure take part the surgeon, one or two assistants, a scrub nurse, and of course an anesthesiologist. And every single maneuver during the laparoscopic procedure is completely standardized and is every time the same in every bypass. This results, to our opinion, in a higher productivity, a shorter surgical time, increased ease, and easy to learn to surgical residents. And due to that, we can create a shorter time in between procedure and have a high turnover rate on one day. And all that results in a very low complication rate. To give another overview of that standardization, trocar placement is always the same, and this is in fact a scheme that is obtained by filming several procedures from the exterior side. And in every procedure that was analyzed by some technical engineers, they saw that every participant, like for example the right assistant, the surgeon or the left assistant, every time did or had the same instrument in the same position during each phase. This is another example of that standardization, and I hope you will see it in the live surgery. This is the closure of the enterostomy. These are 4 cases, 4 pictures, and we always see the same picture coming back. So we try to optimize and to standardize really that procedure. In 2009, we published our results, namely the immediate postoperative morbidity and mortality on 2,606 patients. This is a single center study, of course. We did a retrospective data collection, and we had mainly female patients, namely there was a ratio of 4:1. Age was between 40 and 73 years of age, and the mean BMI was 41. The mean operative time was about 63 minutes with a mean hospital stay of 3 days. Most important complication was in our series the bleedings, that was 3.4%. Important to note is that in the main part of the patients, that bleeding can be managed conservatively by blood transfusion, optimization of the coagulation, and so on. And we had to reoperate in about 23 patients. Bleeding was most of the time extraluminal, that was to say it's on the stapler lines, and we had also 3 bleedings on a trocar side. We had 9 small bowel obstructions, and more importantly 5 leakages, which accounts for 0.19%, which is a very low leakage rate. I think I will show you some other series later on. This is a table that summarizes this. If we look at mortality, another big series, large series, ranging from most of those studies are retrospective studies and multicentric. There are around 60,000 patients retrospective. We see that there's a mortality rate ranging from up to 2.6% to 0.3%. If comparing with our results, we have 0.04%. Looking at the leakage rate, we see a low leakage rate in 1,000 cases by Carrascola. That's a surgeon from Florida, and he mainly performs about the same procedure like us, a fully stapled procedure. It has also a very low leakage rate, 0.1%, but in other large series, 3,000 patients, we see leakage rates up to 4, even to 5%. So we think that due to a maximum standardization of the procedure and a high surgical volume, the gastric bypass procedure can turn into a very low 30-day morbidity and mortality. And by this, it turns into a safe procedure that is easily reproducible and effective for training. So we now further analyzed our cases. We now have 4,000 cases until 2009, I think, and now it is extended, and some of our students are now working on the database, and they told me Friday they had, or Wednesday, they had 5,900 patients included for the bypass procedure. Refinements in the technique resulted in a more substantial reduction of the complications. I'm going to end here, and thank you for your attention.
Thank you very much, Dr. Sebastian. That was a really nice lecture with absolutely fantastic statistics that you showed us. The floor is open now for discussion. If any of you have any questions, Dr. Ilaz and Dr. Razi are going to moderate the session now. After this, we take a quick coffee break. So if there are any questions, it's open for discussion.
Thank you very much for your presentation, Dr. Sebastian. The question is to Dr. Sebastian. I've noticed that you've done a very low number of sleeve gastrectomy. The major impact was on gastric bypass. I wonder, what do you do for patients with BMI of 60 or 65? You go directly for a bypass, or you need to stage them with a sleeve and go for a bypass later on? Patient with high BMI.
I will answer that.
Works?
We try to go for the bypass in first instance, but as you probably know, sometimes high liver volume or previous operations, certainly in high BMI patients, can make that procedure rather difficult. And then we decide on the spot to go for a sleeve gastrectomy, and if necessary, to go for a bypass in the second phase.
Yeah, I mean, the number is very low. It's almost 21 out of 5,000. You have 21 sleeves out of 5,000 bypass. So that means your major work is bypass.
Yeah, I'm sorry to interrupt. 1 of 5,000 I don't think is correct. Now you can see there is a steep increase in sleeves gastrectomies worldwide. You know, the recruitment of patients have started in 2004, studies stopped at 2008. We have to say frankly that at that time, in Europe at least, you know, the sleeve was just coming up. So it was an emerging surgical procedure, which we still, I think, try to do now for the very, very obese patient populations, where you really cannot indeed, like Sebastian said, safely do the procedure, otherwise it would go for a bypass. But there are some specific indications, I think, where the sleeve is indeed a better procedure than the bypass. If you think of patients with the Crohn's disease, patients with extensive adhesions in the lower pelvis, where it's very tough to pull up the small bowel and make a connection of the upper part. But otherwise, I think that the procedure that has really sustained the best during years and years in terms of results is undoubtedly the gastric bypass. One of the big issues still regarding the sleeve is what will be the results after 5 and 10 years. Now, happily there are some reported results coming out after 5 years, seemingly quite well. But I'm afraid, as a lot of surgical specialists, that on the longer end, you know, you're going to see more weight regain for the group of patients who got the sleeve in comparison with that of the gastric bypass. So it is certainly that question has not been answered yet regarding the long-term results of the sleeve. And do not underestimate that in terms of the sleeve, if you go for a sleeve, you really actually remove a big portion of the stomach.
Just to comment on your question, I think in young adult or adolescent group of obesity, we still have to be able to concentrate on non-serious surgical intervention, as Dr. Durmaz has clearly outlined, because we still have a long way to go, because most of these comorbidities don't set in at 18 or 20. So we do have to concentrate in that age group to look at a minimally invasive procedure. And quite often, this is a good indication for patients to have a lap bag, as you rightly said, and bridge the gap of ensuring the other modalities set in before you can actually go in for a serious surgical option.
Very good. I mean, I don't see a lot of leaks. I'm really specialized in getting the leak rate down, because this is the most important complication after surgery. And if you look to literature, you know, leakage rates are very much related to mortality afterwards. So you really have to have your technique completely perfectionized and done quite well. If you have a leak, I think, and if you look to the lawsuits that resulting from bariatric surgery, and for the younger surgeon here present, we may not underestimate the legal impact of operating young patients that work, that have children, etc. It's completely different than do vascular surgery or oncologic surgery. So we may not underestimate that fact. The fact is, if you have a complication, you really have to jump on that immediately, because we are dealing with obese patients with a lot of comorbidities, and the first clinical presentation will be tachycardia, they have some fever, etc. You don't see that always immediately, and even an X-ray could be still normal. But we really do, if you have a complication or the suspicion of a complication, we really jump on the patient, we do laparoscopy as soon as possible. And if you really try, or if you really dare to wait 1 day or 2 days, you know, you see that there's immediately a much more increase in the probability of mortality. So that's certainly my advice.
Doctor, I'm just back from a conference in United Arab Emirates, and what was mentioned there, that in the Gulf alone, we do actually more bariatric surgery yearly than what they do in Europe and the States. Our main problem is that we're all in a private setting, we're not publishing our cases, we're not talking about it. So in terms of numbers, if you take Saudi and Kuwait, Bahrain and Qatar and Oman and put them all together, you see the numbers are actually much more. We are, as a Gulf region, we are doing a lot of bariatric surgery. Because this is all mostly in a private section, this is why we don't know about it. So in terms of the doctor said that we don't have a special bariatric center, you're quite right about that. I know a colleague of mine in Emirates, Dr. Abdeslam, he is doing hundreds and hundreds of cases per month. And he travels between 4 or 5 hospitals. So he would do in each hospital 5 or 6 cases per day. A huge number. Yeah.
I have a question. My name is Dr. Camila, junior surgical resident from International Hospital, Bahrain. The presentation was excellent, and it's an honor to have you here with us. My question is regarding the post-op complication. What's the worst case you have faced, and how did you manage it?
I think that's a nice question, because on that huge number of patients, we don't always remember which was the most dreadful case. The patient who died, I think, honestly said, that was the biggest find. The BMI of 66, coming from the Netherlands. He has been a bartender many years. He smoked 2 packets a day. And was come from the insurance company to me, with a special request. I used to operate that patient. He was wheelchair dependent, etc. I saw this patient and said, Jesus, we cannot make something right. He had already 3 cardiac infarctions in a month. And then I had to send him back. I really said, the risk is too high, otherwise, and we had already placed it into a gastric balloon to get his weight down, to make him a bit more suitable for surgery. But anyway, that was his only life chance he could have. And then we discussed with the insurance, being aware that this was a really, really very risky patient. We did gastric bypass, and eventually he did it very well. And then I think after the 3rd or the 4th day, he then developed a 4th cardiac infarction. And the biggest thing is, that guy is giving me, before the surgery nice present, and really hoping that the post-operative care would have been uneventful, which was not the case. So we developed a 4th cardiac infarction. We did really everything, reanimation, whatever, went to the intensive care, but then finally he died with pneumonia supercoronized from the cardiac infarction. This is what I do remember, because it's a dead patient, was my toughest experience, also regarding to the patient, the family of the patient, If somebody dies, then the words are completely different. In all other complications, you're really fighting for the life, but if you, at the end, you save the life of the patient, okay. But if you lose somebody, that's completely in perception also for the surgeon, that changes a lot. You see, the percentage was 0.04%, which I think the lowest in the world, but still, every patient who dies, even it was so risky, still for us also a psychological burden to take, that's evident.
Thank you, Doctor, for your excellent presentation. I just have a couple of questions. They're quite technical. First of all, I was wondering about your failure rates. What are the percentage of people who actually fail to lose weight to an acceptable level, depending on your definition of failure, of course. The other question would be, now with the emergence of beam surgery, what's your for failed bands or bypasses?
Regarding your first question, we are now really evaluating on long-term results. We started really on high volume in 2004, which is a bit too short to really comment on long-term results. I'm going to show some slides with centers who have started much earlier, so which also more relevant results. Anyway, I think we're going to have the same results that have been internationally reported. I think that also in the gastric bypass, that we really have to focus it on the patient. It still remains a means and tools to lose your weight. It's never going to be the end point of the obesity problem. We still are faced with some patient gastric bypass who regain weight, or who have unsuccessful weight loss from the start. I think the percentage which is now accepted is 15%. And I really think if you look to our results, I think it's going to be the same. If we really look to it data to the patient, then we see that loss of compliance, and by this also loss of restriction, it could be also a bit caused by pouch dilation or whatever, is the major cause why the patients have failed to have good results on the long term. But like you've shown in the study of Shastro, it's certainly the best procedure. The only fight will be the BPD or the DS, but there are much more invasive procedures. I think that 15% is a very acceptable